So a very good evening to all of y'all. We are once again back. It's 9 p.m. on Tuesdays. This is the 12th episode of the PG teaching series by Dr. D.Y. Patil Hospital and Research Center. I request Dr. Biraris, who is the examiner for today. We are going to have a short case on its knee examination to be presented by one of the exam-going candidates, Dr. Akshat Pandey. And the examiners, as I said, Dr. Sandeep Biraris, sir, Dr. Vaibhav Kohli, and Dr. Aditya Gunotikar. I hope you can introduce yourselves and we can start with this.
Yeah, I welcome Dr. Sandeep Biraris, who is the clinical head in the Bombay Portress Hospital. He is an arthroscopist himself and a joint replacement surgeon. I thank him for giving consent to this teaching program at a very short notice. I welcome Sandeep, and I think Aditya will join in a few seconds. Akshat, you can start the presentation.
Good evening, sir. I am presenting a short case of a 21-year-old male, case of right-sided ACL deficient knee with lateral meniscus tear, with Latchman test positive, lateral McMurray test positive, and Acl Reconstruction test positive, with a functional impairment of pain and swelling in right knee since 6 months and difficulty in walking since 6 months. The patient was apparently asymptomatic 6 months back when he developed pain in his right knee, which was insidious in onset, gradual, progressive, aggravated, associated with swelling, aggravated on movements, relieved on rest. The patient also gives a history of trauma 10 years back when he fell from a bicycle, and according to him, he sustained injury in his right knee, and he was taken to a local hospital where they said that he got a fracture. So he was put on a cast for 2 months, and was after the cast, the patient said that he only had occasional pain in his right knee, which he ignored, or very occasionally he took medications for that. But he never got any functional impairment because of that. And it was also past 6 months, he also complains of instability while walking, climbing up and down stairs, walking on uneven ground, and walking for prolonged time. So the patient gives no history of any fever, weight loss, or any constitutional symptoms, or any history of joint stiffness or morning stiffness. So past history, apart from the history of trauma, there is no significant past history, no past history of any surgical intervention, no history of any. Yes,
your voice is not that loud. I think you keep it properly. Everybody should hear properly. It is coming as a remote से आवाज आ रहा है, ऐसे लग रहा है.
Yes, sir. So past history. Apart from the history of trauma 10 years back, the patient gives no other history of any trauma since the start of the complaints, or any past surgical intervention. The patient gives no history of any comorbidities. Personal history, the patient is the tailor by occupation. He has a mixed vegetarian diet. And the patient has a normal sleep pattern and bowel habits. Family history is not significant.
Why history of comorbidities you have asked in 21-year-old? If at all you want to ask, there are 2-3 specific things you have to ask in him. Since the history is of 10 years duration,
yes, sir.
Means that means he sustained injury at the age of 11.
Yes, sir.
And now he has become symptomatic.
Yes, sir.
So
for a history of any asthma, because he had to take steroids for it.
So meniscal tears increase if the patient takes steroids, you mean to say?
No, sir. It can increase degeneration of the ligaments. Degeneration of the ligaments.
Degeneration of the ligaments.
Or sir, in other cases of knee diseases like necrosis of femoral condyles, it can cause.
You want to say that it could be spontaneous osteonecrosis of the knee.
So, osteochondritis dissecans could be one of
तेरा आवाज नहीं आ रहा है सुनने को.
So osteochondritis dissecans could be
osteochondritis dissecans. Okay.
Is that related to steroids though?
So it can cause aseptic necrosis of the subchondral bone.
So what are your positive findings only on history?
So positive findings on history include pain and swelling in his right knee and instability while walking for long duration of climbing up and down stairs and or walking on uneven grounds.
Any history of locking or unable to flex or extend the knee?
No, sir.
Sure.
Yeah, please, Dr. Aditya, please go.
Okay, thank you. Akshat, he had
Yes,
a 10 years ago, right?
Yes, sir.
And his pain and instability is on 6 months.
Yes,
right? So, बीच में का 9.5 years, he was completely asymptomatic.
No, sir. The patient says that he used to have pain while cycling for a long time or while playing, but the pain was very less, and he used to ignore it, never used to take any medications for it.
Those symptoms are not very severe, no? If the patient himself thinks there is no need to do anything.
Yes, sir.
Okay, what are your other findings? So please continue. Sorry, sir.
Yeah, correct. Same question. Correct.
Yeah, thank you, sir.
So what are your other findings? Or we can say, what do you think could be DD only on history?
So on history, I would like to give my differential diagnosis as a post-traumatic soft tissue injury, which can be a complete or partial tear of anterior cruciate ligament or lateral meniscus, or it could be osteochondritis dissecans.
Lateral meniscus on history, how did you come to that conclusion?
So because the patient used to say that on walking, he used to experience pain on the lateral side of the knee joint.
Okay.
Do you give such diagnosis with precision based on history? That is what Biraris sir was asking. How can you be so precise? Can you just not say it can be a cruciate ligament injury with a meniscal tear, a possible concomitant meniscal tear?
Yes, sir.
You can say that, right?
Yes, sir.
Because if he sustained injury 10 years back, like you're saying, how well would he remember the mode and the velocity and the type of trauma, the mode of injury, the direction, all that? He cannot, na? It is impossible for him to precisely remember all of that. So you cannot say that ye XYZ, yehi wala meniscus will be injured or yehi wala cheese will be injured. Okay, soft tissue injury, I accept it. But you cannot be this precise based on your history at least. Are we clear?
Yes.
On inspection, what are your findings?
Sir, on inspection, say attitude of the limb, the hip and knee are in extension position with the patella facing upwards and outwards, and the foot is in plantar flexion. So there is no visible, there is mild swelling present on the lateral aspect of proximal knee, and there is no visible dilated veins of skin discoloration or presence of any fistula, no visible bony deformity. So I inspected the patient in standing, sitting, supine and prone position from front, back, and side.
No. Wait. On inspection, is the patella at the same level as compared to the opposite side?
Yes, sir.
It is at the same level?
Yes, sir.
What is patella alta?
High riding patella, sir. Anterior door test. Sir, in this first we will do a 15-degree internal rotation, and then again I will do the jerky movements, and if the lateral side of the knee will the anterior door test increases, the lateral side of the knee pushes forward, then that means the anterolateral structures like LCL or lateral capsule is also deficient. And by doing it in 30 degrees extension, if the anteromedial aspect of tibia pushes out, then it means MCL tear or medial capsule tear is also there along with ACL.
Okay. Is LCL a part of anterior structures or no? Simple question.
No.
Yes or no answer?
What is the question, Aditya?
Is LCL a part of anterior structures or posterolateral corner? Just modify.
तुझा पण आवाज कमी येतोय आदित्य. काय कळत
Posterolateral complex.
So you LCL in a drawer test, no?
Yes.
What are the components of the posterolateral corner?
Sorry, sir.
What are the components of the posterolateral corner?
Components of the posterolateral corner include lateral collateral ligament, popliteus tendon, lateral head of gastrocnemius, arcuate ligament.
Tell me the third major component.
Arcuate ligament.
Nice. Read up.
Yes.
Okay. So what are the parts? So please go ahead.
Yes, please. Aditya, please go ahead.
What are the structures at the anterolateral part of the knee?
Sir, IT band.
Okay.
So lateral retinaculum, sir.
और बोलो.
Then capsule, so lateral capsule.
Capsule is going to be all around, yeah, Akshat.
Sorry, sir.
So please, you're asking something, sir?
Yeah, Dr. Akshat, which test you said is positive? Only Lashman.
So Lashman test, sir. Lashman test and yes, sir.
Yeah. So how you quantify or grade this Lashman test? If it is positive, so there are some grading. What are those?
So for Lashman test grading is if the displacement is 1 to 5 millimeters, and is grade 1, 5 to 10, 6 to 10 is grade 2, more than 10 is grade 3.
Good, correct. So one more thing, like, do you know something about a door stopper effect?
Yes, a door stopper effect is provided by the posterior horn of the medial meniscus. It happens when in flexion the condyle of the femur gets in the posterior horn, and when it does not allow the tibia to move forward. So in that case, we can get a false negative anterior draw test.
So how do you negate that?
The Lashman test.
Sorry?
By Lashman test, sir.
Okay, correct. Please go ahead.
Yes, sir. So then I did a varus and valgus stress test to rule out medial and lateral collateral ligament injury. And then I also did posterior sac test and posterior draw test. Yes,
Akshat, what was the varus and valgus stress test? Positive or negative?
it was negative. It was
Negative. Okay.
Yes, sir.
Akshat, agar I'm doing the valgus stress test in extension and it is positive, what is the interpretation? Hear me out again. I'm doing the valgus stress test in extension.
Yes.
क्या interpret होगा?
So that means the medial collateral ligament as well as the posterior cruciate ligament can be injured. And if you will do it in flexion,
it's not posterior.
should I continue?
Akshat, what is posterior oblique ligament? Now that Dr. Rohan has asked you about valgus stress test and extension, what is posterior oblique ligament?
Sorry.
What is the function of the superficial MCL?
It provides medial stability to the joint.
In all degrees of flexion, as well as extension.
I don't know.
Superficial MCL is a primary restraint to valgus in flexion, and primary restraint to valgus in extension is the posterior oblique ligament.
Yes.
Please continue.
Yeah. So to check for meniscus, I did the McMurray's test for both medial and lateral meniscus. For it was positive for lateral meniscus. And I
Dr. Akshat.
Yes, sir.
Hey, I just want to ask one thing. Do you have any other test for ACL other than Lachman, anterior draft, and pivot shift? Very sensitive. Do you know Lilly's test?
No,
Hello?
no, sir.
Can you hear me?
Yes, sir.
Do you know Lilly's test? If you know, then can you demonstrate first and give the inference? You don't know. Okay, go ahead. Read about that.
Yes. So for McMurray's, lateral McMurray's was positive and Apple's grinding test was positive. So for posterior cruciate ligament, I did the
demonstrate McMurray's for lateral meniscus.
Yes. मैं आपको फाइल दे दूँ, ठीक है? अगर फोन देना, अगर आपको दर्द होता है तो मैं तो बताऊँ. So first I will flex my knee and the heel, hip and knee both, and the heel should touch the ischial velocity. For to check for the lateral meniscus, I will internal rotate the foot, apply a varus test, and then I will extend the knee. And the patient is complaining of pain at the end of the movement. So if it's pains at the start of the extension movement, then it signifies a posterior horn tear. If it occurs in the middle, then it suggests body tear. And if it happens in the end, then it is more suggestive of an anterior horn tear.
Okay. What are the other tests for meniscus?
So I did Apple's grinding test.
Other tests apart from these two. Do you know? I'm not asking you if you did. I'm asking you, do you know of any other meniscal test?
No, sir.
Okay, continue.
Yes, sir. So then, to check for posterior cruciate ligament, I did the posterior dot test and SAG test and quadriceps active test. So it was all were negative.
Okay, Akshay, just stop here.
Yes,
If there is a PCL tear,
yes, sir.
will you do the anterior draw test any differently or the same?
So if there is a PCL tear, first I will check, sir, whether there is any posterior sagging or not. If there is any sagging, first I will correct this by pushing the tibia first. Then I will perform the anterior draw.
How do you know the sag is corrected? What will you look for?
So the ischial tuberosity, sir, it will.
What?
The ischial tuberosity, sir, it will.
Ischial tuberosity कहाँ से आ गया?
So I will feel the lateral proximal tibia, lateral border will come up, sir.
Sorry, come again, please.
With my thumb, I will feel the lateral proximal tibial border of the tibial plateau to come in line with the lateral femoral condyle.
Is the lateral tibial condyle normally in line with the lateral femoral condyle?
It's 1 centimeter ahead.
So if there is a posterior sag and you're checking, you're saying you will correct the posterior sag by bringing the tibia in line with the femur. Do you think you're going to get a proper test result?
So 1 centimeter.
You have to recreate that anterior tibial step off. That is after which you will do the draw test, or you might get a false positive result, no?
Yes.
Continue.
So after my examination, I would like to give my
examination हो गया?
I would like to give my differential diagnosis as ACL.
Stop.
Yes, sir.
Are you done with your examination?
3 important things you are supposed to comment before you come to the diagnosis. What is left now?
So the gait of the patient.
No. Any distal neurovascular deficit?
No, sir. No deficit, sir.
So you have to tell, no, because it's a 10-year-old injury.
Yes, sir.
Any other laxities anywhere in the other joints?
No, sir. There's no other.
Have you checked?
Yes, I checked, sir.
Why you have to check laxities in the other joint?
So to rule out any Marfan and Ehlers-Danlos syndrome, which can cause multiple joint laxity.
So did you check that?
Yes, sir.
Sure, huh?
Huh, sir.
Okay, if you have checked that, what is his Baton score?
आदित्य,
Yes, sir.
जरा त्यांना घ्या जरा कधीतरी वेळ मिळाला की सगळ्यांना.
सर येत नाही लोक.
तुम्ही बिझी लोक आहात बाबा, सगळे लेक्चरर, संदीप बिरारी, सगळे बिझी पीपल. मालूम है स्कोर?
I did not measure the score.
स्कोर बोलेगा तो थोड़ा जास्ती पॉइंट्स मिलेगा, बट यू आर डूइंग वेल. ओके. Examination of the knee joint from the behind. It is very important. Examination of the knee joint is not complete till you examine the knee from back. So did you make the patient stand and examine him from the back?
Yes, I had.
What you are supposed to check in the back of the knee posteriorly?
So posteriorly, sir, first I will check for any deformity in the legs.
Deformity nahi re. Common चीज क्या रहेगा वो?
Pubica cyst.
So you have to check for any posterior fullness in the knee joint.
Yes.
Okay. If it is fullness, any other things you must keep it in mind posteriorly.
Popliteal aneurysm, sir.
So examination of the knee joint is not complete till you examine the knee from the back. Any other things, Aditya?
What is the test for PLC injury? You said lateral sided pain, no? pain and swelling. Test for PLC becomes important. What is the test for PLC?
So, dial test, sir.
You did not mention the dial.
Which meniscal tears are common, Akshat? Medial meniscal tears are common or lateral meniscal tears are common?
So, medial meniscus tear.
Why?
So, because it is attached to the capsule throughout its peripheral process circumference, the mobility is less of medial meniscus, whereas the lateral meniscus is a bit mobile. So, the longitudinal tears are common in medial meniscus tear.
Arey, the speaker phones are on, yaar. Whoever is watching the. Okay, what is your diagnosis? Hello.
Yes, sir.
Yeah, what is your diagnosis?
Sir, based on my history examination, I would like to give a diagnosis of ACL, right-sided ACL tear with the lateral meniscus tear.
Okay. How will you manage this patient now?
Just 1 minute.
21-year-old electrician by occupation.
Okay.
According to you, 11 years old, injury to the knee.
Yes.
Sir, just a minute. I'd like to stop him here. You
Okay.
said the anterior drawer test was negative and Lachman was positive, right?
Yes, sir.
Pivot shed
Yes, sir.
test was negative.
Yes, sir.
Okay. Slocum anterior drawer was negative, right?
Yes, sir.
Okay. So you think this will be a complete ACL tear?
So it can be a complete ACL tear because other structures will also compensate. It has been 10 years compensate for the function of ACL. And
But he did not have
Lachman test.
but he did
Yes,
not
sir.
have instability for 9.5 out of those 10 years, no?
Yes, sir.
What are the parts of your ACL? What are the bundles of your ACL?
So ACL is composed of two bundles, anteromedial bundle and posterior lateral bundle.
Could this test be a partial AC? Could this be a partial ACL test
This could be,
with
sir.
injury to one of those two bundles? Which
Yes,
bundle?
this could be, sir. So in Lachman, the posterior lateral bundle is more short, so rupture of posterior lateral bundle can be there.
Okay.
What was the end point of your Lachman test?
So it was soft, sir.
Soft. So what is the difference when it is soft or when it is hard? So what does that signify? I think that's what is I think Dr. Aditya is trying to ask you.
Yes, sir. Exactly.
Sir, we get a firm point or a hard point when the structures are ACL is intact. There will be a sudden stop while doing the Lachman test or anterior drawer test. But if there is any tear in the ligaments and we will push the tibia towards ourselves, then the end point will be not sudden. And we will have to compare it with the opposite side also.
Okay.
Chalo, how will you manage this patient now?
So I will like to get his standing X-rays, anterior, posterior, and lateral views.
Lagao, X-ray lagao.
Okay.
How can you diagnose on X-ray ACL or a meniscal tear?
Sir, I would like to get the X-rays for seeing the joint space first, because in case of tears, chronic tears, the joint space might be reduced, or at the time of injury 10 years back, he might have sustained any avulsion fracture, which could be seen on X-ray as a heel fracture or not.
No, forget about the old injury. You can still find out if there is a ACL or a meniscal tear on an X-ray.
Sir, in case of any avulsion injury of the tibial
Not avulsion. Avulsion to दिखेगा ही ना. टिबियल एमिनेंस तो थोड़ा ऊपर आएगा. Forget that. Anything else? Any third year? Third year, who are there? Ganesh, Rohit, Maitreya.
Stress view, sir.
Huh?
Stress view, sir. Anterior, posterior drawer and varus valgus stress views.
Stress views can give rise. You can come to the conclusion of collaterals. No.
Even anterior drawer stress view and posterior drawer stress view.
So it's on a single standing AP X-ray. That's what sir is asking.
My question is first that. Please read up.
Yes, sir.
It is there. Akshat, how will you manage now? X-ray is normal or abnormal?
So I can see a old heel fracture in the tibial eminence, and there is a piece of bone jutting out of this. I think it could be a healed old fracture, sir. Tibial eminence. Fracture.
Is it healed in a normal position?
No, sir.
See the lateral X-ray. What is seen in the lateral X-ray?
In lateral X-ray, we can see the position of the patella, the blue line, and
Go slightly up near the joint line. What is that?
I think it's the healed old fracture.
What will you do now?
So for this, I would like to get an MRI done. So this is the T1 weighted image of a sagittal section of the knee joint.
Akshat, stop. Akshat, stop.
Echoing of your voice here.
Akshat, your voice is echoing. You have to stop.
This DYP laptop voice can be muted. DYPH. I think the echo will go.
Yeah. Just try now, Akshat.
So this is the sagittal T1.
No, it's still echoing. Wait, hold on.
Echo is still there.
Mute the laptop voice. Poonam, you can mute DYPH.
Hello.
So this is the T1 weighted image, sagittal view of the knee joint, which is suggestive of the first. It is coming from lateral to medial side, and we can see here.
जो कैमरा क्लोजअप ले रहा है उसको बंद कर.
Akshat, mute yourself. Your mobile. Akshat, iPhone mute karo.
Your voice is still echoing.
I think the camera which is taking the close up
or DYPH.
जो हमारा ना कैमरा जो viewing इस पे now speak.
Am I audible?
Yes, please continue.
So this is the T1 weightage image, sagittal view of the knee joint. So we are coming from the lateral side to the medial side. We can see the fibula, and so this is the lateral anterior horn of the lateral mills. We can see a tear. We can see a tear in the anterior horn, while the posterior horn is intact.
Does it confirm your diagnosis?
So I would like to see other views also, sir. T2 weightage image.
Anything in this image? Anything below? Yeah, the lower left two images.
This also?
Yeah, something there.
What is that, Akshat? Where your cursor is?
So I think this so there degeneration of the proximal tibia.
Degeneration of the proximal tibia.
Cyst in the proximal tibia.
How does it look as compared to, like, you can always compare with surrounding, if it is a soft tissue, bone, fat pad, muscle, you can always see how it looks like in the image. Is it a soft
How is
tissue?
the cartilage? Is it normal or are there any defects in the cartilage? Since you told it is 10 years old injury.
Cartilage is, it looks degenerated, sir.
Cartilage is?
Degenerated.
सुनने को नहीं आ रहा यार, कुछ तो गड़बड़ है ऑडियो में आज. There is some issues with the audio, huh?
So the
बोल अक्षत. Cartilage is degenerated. Please show me where. Is that a cartilage or is that the bone where your cursor is right now?
So this black region is cartilage. It's not there.
Please continue. So here, your cursor, that's the bone, no? The spike of the bone.
Yes.
That is your malunited ACL tibial fragment with lot of cystic changes around.
Yes, sir.
What will you do now? You have seen the MRI, come to some diagnosis, you have examined the patient. Will you operate, not operate, leave it alone, conservative?
Sir,
what patient wants and what you want to do?
So as the patient is complaining of instability, I would like to go for operative management, but first I would like to do a diagnostic scoping.
What?
So you'll post the patient for diagnostic scopy, then post him for surgery again later on?
No, sir, depending on my findings in the diagnostic scopy, I will decide my what kind of surgery I would like to do.
Do you have T2 sagittal?
Yes.
Next image, it's all. No. Yeah.
So here we can see edema in the anterior part of the lateral meniscus. That means there is the radial tear, and I would like to repair it. But if it is not possible to repair, I would like to do a meniscectomy in this case.
How will you repair a lateral meniscus anterior horn?
So from outside in approach.
Outside in, okay. Please comment on the ACL.
The ACL looks intact, but there are edematous changes seen. So it looks a bit degenerated. So if while doing the scopy, the substance of the ACL is good enough, then I would leave it, or otherwise I will do the reconstruction.
You think the ACL is going to look normal in this case with so much edema around?
No, sir.
Any other finding on this MRI? Anything apart from you commented about meniscus, you commented about ACL, something else? How is the PCL?
So the PCL is intact, sir.
Okay, but how is it?
It is bulging back. It is bulging back.
What does that indicate?
Isn't it a wavy?
It is seen in lax ACL tear or ACL laxity.
Correct.
Akshay, the PCL will be seen torn in a PCL tear. A lax PCL will be seen in ACL tear. It's an indirect sign.
Yes, sir.
So that is what sir is asking. Now, does that change your management now?
Yes, sir, I would like to go for ACL reconstruction now.
And what will you do to the meniscus? Repair it.
Yes, I would attempt to repair the meniscus.
And what will you do to the bone inside the notch? You think this meniscus is going to be as simple as doing an outside in meniscus repair?
No, sir. I would do.
You'll do an ACL reconstruction, right?
Yes, sir.
Okay. Which graft will you use?
So I can use a bone patellar tendon bone graft or a quadruple hamstring graft.
Before the graft, show the sagittal and axial images, please. Sorry, coronal and axial images. Sorry, coronal and axial images.
This is the actual image, sir.
Go to the coronals. What is a parameniscal cyst?
The parameniscus is seen in the meniscal tears.
So what happens in meniscal? Do all meniscal tears cause a parameniscal cyst?
No, sir. Parameniscal cysts are due to the joint effusions in the joint because tear in the meniscus. I don't know about the parameniscal tear. Yes, sir.
Okay, please read up.
Yes, sir.
Coming to the ACL reconstruction now.
Yes, sir.
Which graft will you use?
I would like to go for a hamstring quadruple graft, semitendinosus or gracilis.
Why? Why do you choose a hamstring graft?
So because it will cause other graft is bone patellar tendon graft, but it will cause more anterior knee pain.
Hamstring harvest will not cause any pain?
So it will also weaken the quadriceps mechanism of the knee also. Extension of the knee will be get affected. And pain will be more in case of patellar graft as compared to hamstring graft.
Any other graft you can use?
You can use peroneus therapy for at least 6 to 8 months.
So when you think he can return to like his normal activities, like cycling and all, when can he resume?
At least minimum 6 months.
I mean, not time. I'm not asking time frame. What do you think could be the criteria? Well, now, as you have already said, there is no vesting in this patient, but I really doubt it. So the single most criteria is there should not be a visible vesting at the end of the rehabilitation. So when you can see clinically there is no vesting in either of the limbs, both are comparable visibly, that both calf as well as thigh muscle. That means you can release him for the his routine activities, or we can say sporting activities. That means he has been rehabilitated properly and effectively.
Yes, sir.
Anyone would like to ask anything? I think Sunil sir has also joined.
Akshay,
Yes, sir.
this is a case of malunited tibial eminence fracture, na?
Yes, sir.
So why not remove it and reattach it to its normal anatomy? Why do you want to take graft from it?
So the main complaint of patient is instability.
To stabilize it by putting it in its normal anatomy. No?
Yes.
Can it be done?
Yes, sir, you can.
If it can be done, Akshay, then why aren't you doing that as your treatment plan?
So because the patient is not, the primary complaints can be solved with the repair. I don't know, sir. I have to update it. And there are attachments of other structures on the tibial eminence. So
This fragment that you see, what other structure can be attached to?
sorry, sir.
So please go ahead, ask your question.
Yeah, if this patient would have presented to you on the day one of the injury, the same this injury, so what would you have offered him for treatment modality?
I would have waited for, I would have given him a long knee brace, and I've opted for surgery after 3 to 4 weeks.
Why 3 to 4 weeks? There is a meniscus tear and elevated comminuted tibial eminence ACL avulsion. So, why did you choose to wait for 3 to 4 weeks?
So because initially there would have been hemarthrosis and lot of edema, so first we couldn't do the MRI for the first 10 to 14 days.
Akshat, what surgery are you planning after 3 to 4 weeks of initial resting?
So I would first repair the meniscus and fix the avulsion fracture with anchor suture.
Anchor suture, okay. So why wait 3 to 4 weeks?
We wait for the not 3 to 4, at least 2 to 3 weeks or to wait to so that the edema decreases and the hemarthrosis also decreases. It will hamper in the
Apart from suture anchor, any other fixation modality?
We can 2 days then.
In acute.
I don't know.
So the non-arthroscopy surgeon can put the fixation with the screw. Arthroscopy surgeon can fix it with, as you said, suture anchor is also there. Then again, pull-out suture technique is there.
Yes.
Which ACL avulsions will you operate, Akshat? How will you decide if this ACL avulsion needs surgery?
So it will cause instability.
Acute है ना भाई? You're choosing in an acute situation, no? You think you can do any test for